page. And so Dr. Olanike Olutekunbi is I haven't met her in person, but having worked with her across the weeks in preparing for this call, she is such a charming and easy to work with, healthcare worker who is really passionate about what she does. And you see that as she presents. She's a consultant, pediatrician, and a neonatologist. She's the head of the medical department of Mercy Children's Hospital, Lagos, which is one of the busiest hospitals, children's hospitals in the whole of Lagos. She's earned her medical degree from University of Ilorin. She's a fellow of the West African College of Physicians. She's a member of the sub-technical committee of the Lagos State Maternal and Perinatal Disease Surveillance and Response, and her special interests are in nutrition, neonatal resuscitation, and essential newborn care. So you should see that she is really, really, primed and a good fit for the topic that we have today in service of the little ones. So we've stopped sharing her slide so that Dr. Olutekunbi can share her slide. But before she starts presenting, we chose this topic. We work with a lot of women on the Complete Health platform, which is the mDoc digital platform. And in talking with the women, we saw that our health coaches realized that a lot of women after giving birth had babies with neonatal jaundice. And unfortunately, led to the death of some of them, with some women not even having the resources to, care for it, or that reluctance to treat it. And so we felt that this is really an important topic to handle, hence inviting Dr. Olutekunbi to discuss this. So over to you, Dr. Olutekunbi. I believe that you are co-host and you can share your slides. Okay, it's coming up now. Over to you, Dr. Olutekunbi. Thank you so much for joining us and speaking today.
Thank you very much. Thank you so much. Good afternoon, everyone. It's a pleasure to be here with you this afternoon. The topic for today, it's not a strange one, it's a common one. And I'm sure I will learn also from interacting with you. So that we don't waste too much of time, I will go on to the subject topic. And at this time, of course, you've talked about everything that has happened in the nation. It's been traumatic for everyone, and I commiserate with all the families that have lost their loved ones at this time, and pray that God will continue to help us and sustain us this period in the name of Jesus. Thank you. So, what are our learning objectives? We'll be looking at the topic through these objectives. We'll have a brief introduction, and then we'll learn the common causes of jaundice and differentiate between pathologic and physiologic jaundice, how to manage jaundice, know the possible complications, and then go on to the case presentations. By definition, jaundice is the yellow coloration of the skin and sclera in the newborn, and it occurs as a result of accumulation of unconjugated bilirubin. And the who is a neonate is a baby that is less than 28 days. So that defines it, neonatal jaundice. That's jaundice in a baby that is less than 28 days old. So globally, jaundice is a common medical problem among neonates, particularly within the first week of life. In developed countries, progression to bilirubin encephalopathy, which is what we fear the most when we manage jaundice, is uncommon. However, it is not the same in Nigeria, where it has remained common and is one of the causes of morbidity and mortality in Nigeria. Nigeria has one of the highest rates of kernicterus in the whole world. it is always, nearly always preventable, so it does not have to happen. And so this is the best time, and I really appreciate Dr. Kendra and her team for bringing this up at this time, especially now that Nigeria ranks the highest in under 5 mortality all over the world. And when you look at the under 5 mortality rate, a huge chunk of it, about a third of it, is due to neonatal mortality. So if we all work together, with this building capacity, work together and reduce neonatal mortality rates by reducing jaundice, we would have done something to bring down these mortalities. It's a very common neonatal emergency. Most of the time in emergency room, the neonates are coming with neonatal jaundice. 30 to 80% of newborn develop some degree of jaundice in the first week of life, especially in the preterms for very obvious reasons. So you need a detailed history and thorough investigation to reveal the cause in most cases. For every death due to neonatal jaundice, 2 to 3 babies have residual neurological deficits. So most babies with the encephalopathy are already affected at presentation. Experience of mercy, you see most people rushing the baby in the evenings off the naming ceremony, with the mother still putting on, having on the lace material she used for the naming. So you see, it's very pathetic. But with capacity building, talking to people, passing down information, we can curb, this problem. So why should we worry? A child with neonatal jaundice, because of the obvious complications that can result. Complications like deafness, neurologic problems, ultimately leading to cerebral palsy. But there's some spectrum in between, like learning inabilities and all of those things. And then kernicterus, and ultimately death. So what are the types of jaundice? Jaundice basically can be physiologic or pathologic. Physiologic jaundice is usually noticed from the 2nd to the 5th day of life, and it usually disappears by the end of the 7th day and resolves completely by 2 weeks of life. The peak serum level is mostly less than 15 milligram %. But for pathologic jaundice, it occurs within the first 24 hours of life, with a rising bilirubin greater than 5 milligram per dl in 24 hours, and greater than 15, serum bilirubin greater than 15 milligram %. Bilirubin is formed from the catabolism of heme containing products in the reticuloendothelial system. I don't want to go too in-depth into this, but just to know that it is formed from the breakdown of heme. Heme is gotten from blood or from other sources like myoglobulin or the cytochrome system. But the breakdown of all of this, results in bilirubin. So this shows graphically what we're saying. Heme is derived from any of this, and by the action of heme oxygenase, it is converted to biliverdin, to bilirubin, and then it is conjugated by glucuronidase transferase to conjugated bilirubin. This form is the safest form. We're not usually scared of conjugated bilirubin. So this shows the seat, of metabolism. You have the breakdown, to unconjugated bilirubin in the blood. And then another seat is the liver cell, the hepatocytes, where conjugation, occurs. And then secretion into the small intestine, where bacteria acts on it to form urobilinogen, which gives the color to feces. Some urobilinogen goes into the kidney, and is excreted in urine. So That is the pathophysiology in brief. Neonatal jaundice is relatively more common in the newborns, in the newborn period, than in adults. And the newborns have a greater red cell mass and a shorter red cell life cycle. So the normal term newborn produces about 6 to 10 milligram of bilirubin, in contrast to that of the adults. So they have a huge red cell mass. When it breaks down, of course, they have a huge bilirubin load. Also, there's a greater rate of production of bilirubin from other non-erythrocyte sources than you have in adults. And then enhanced enterohepatic circulation due to reduced intake in the absence of gut flora in the first few days of life would also cause jaundice. That is breastfeeding jaundice. So what are the causes? What are the causes of jaundice? We'll look at it, under some subtopics like increased breakdown of red blood cells. This usually occurs from isoimmunization, that is rhesus or ABO incompatibility, or incompatibility of some minor blood group, but majorly rhesus and ABO incompatibility. It can also be, as a result of red blood cell enzyme defect. And the commonest one is the G6PD deficiency, especially in the male newborns who are exposed to things like naphthalene balls, camphor, mentholatum, and all of those things. Even before the babies are delivered, the mothers, already have what is called a jogba. And inside of it, they have all the baby products, powder containing methylated substances and all of those things. That, can cause jaundice in a G6PD deficient child. Other, such as the red blood cell structural abnormalities from hereditary serocytosis, infection would cause jaundice. Polycythemia, the huge red cell mass, and then shortened lifespan of the fetal red blood cells, as a lifespan of 80 days compared to that of the adults. And then wherever you have sequestered blood, like cephalohematoma, bruising, intracranial hemorrhage, it will cause jaundice. Okay, so the causes of unconjugated hyperbilirubinemia jaundice. So another is increased enterohepatic reabsorption. We have said it, the child is not feeding, the child is being starved for one reason or another. The mother has not put the child to breast within the first 30 minutes of life, or the child, is having feeding difficulties. All of this would cause increased enterohepatic reabsorption and release of free bilirubin. And then anything that causes bowel obstruction in the child, and then the child not taking enough, would cause jaundice. So I put this here really just so that we just know. I'm not going to spend time on this at all, because conjugated hyperbilirubinemia is a huge topic on its own. But just for us to know that, yes, it can happen. Again, don't forget, we already said that, bilirubin gets conjugated by some enzymes, to albumin. And then the conjugated form is relatively safe in quotes, because it does not cross the blood-brain barrier so early to cause bilirubin encephalopathy. But of course, we need to know that some of these things, would give us conjugated hyperbilirubinemia. So in summary, let's look at the risk factors for jaundice. I've tried to just put it together, you know. So jaundice within the first 24 hours of life is a risk factor for any newborn. So, and a sibling who has had jaundice as a neonate is a risk factor. So that's the place for there's a place for proper history taking in this scenario. Unrecognized hemolysis is a risk factor. Non-optimal suckling or nursing, not feeding, starving the babies is a risk factor. Deficiency of G6PD is a risk factor. Infections and then concealed bleeding, cephalohematoma, bruising is a risk factor. Then East Asian or children of East Asian or Northern Indian descent are at risk for developing jaundice. For those of us that practice in the big private hospitals, the descent, children of East Asian, Northern Indian descent they have a risk factor for developing jaundice. So the gestational age less than 37 weeks is a risk factor. We've talked about G6PD, we've talked about jaundice in the first 24 hours of life. Exclusive breastfeeding is a risk factor. Now, in some children that are exclusively breastfed, you just find the serum bilirubin level rising and rising and rising. Now, let's remember that making this diagnosis is a diagnosis of exclusion. In this kind of child, you would have excluded every other cause of jaundice. And then what happens basically is that some mothers secrete a particular steroid in their breast milk that competes with albumin. And so they displace bilirubin, competes with bilirubin for albumin, displaces bilirubin from its binding site, attaches to it so that you have free bilirubin in the system. But the good thing here is that there's not been any reported case of kernicterus from breast milk jaundice. So an older sibling with neonatal jaundice that requires phototherapy, I think we mentioned it, and then it takes factors for developing jaundice. The macrosomic neonate of a diabetic mother, and then studies have shown that the use of oxytocin or vacuum delivery also predisposes the child to developing jaundice. So how do they present? General symptoms are, of course, you see the mothers will say, oh, the baby is yellow, the eyes, the sclera yellow, and the baby is sleeping excessively with poor feed. They may talk about the color of the urine. We already know that, in the pathophysiology, there's some excretion, in the urine of the byproducts. And then fever. Fever is a pointer to an infective process. High-pitched cry. I hate to hear this cry. It pierces my heart so much because I know when I hear it, some degree of complication as setting, and then other signs like vomiting in the child. So what do we do? Oftentimes, in practice, we have problems with laboratory results, But what I've tried to do here is, so what do we do at the bedside? How do we measure, that's the rule of thumb. What do we do? So when looking for jaundice, doing a visual inspection, you need bright, natural, and bright light, but preferably natural light. Natural light works better for me. And you must expose the child, examine the sclera, the gums, blanch the skin. This, have been reported that it's useful across all skin tones, but I find it difficult, to use this in very dark babies. But hey, that's information. So now for the rule of thumb, the Kramer's index, what you do, what if jaundice is limited to the face alone. Okay, so you say the estimate is most likely 5 milligram per GL. So the upper trunk, about 6 to 8 milligram per GL. The lower trunk and the thighs, about 9 to 12. And then up to the toe, palms and soles. When you see jaundice up to the, you definitely know it is greater than 15 milligram per GL. And so it helps you, to prepare for how you would intervene in managing this child. For instance, if I'm seeing the child palm up to palm, and so I begin to, I take the blood quickly, I begin to prepare for EBT until I get my serum, and then also match some clinical things together. Between 13 to 15, of course, 9 to 12, more than 12, I start phototherapy, So this is a rule of thumb to help in managing the children. So there are other things, that we use while waiting. We can use while waiting for the lab results, because in some of our centers, it is a problem really getting bilirubin results. Sometimes the results are not accurate, so you need to match the results with your clinical acumen. Anyway, so this is a point of care equipment that can be used. Some centers, this one uses just a drop of blood, and then it gives us the result in about 60 to 90 seconds. There are other equipment like the jaundice meter, that can be used by the bedside. So, what affects the management of jaundice? The gestational age of the baby is very important. The management of jaundice in the preterm is not as straightforward as in the term newborn. The age of presentation also matters. For instance, if I'm seeing a child present with jaundice within the first 5 days of life, with serum bilirubin of about greater than 12, I will intervene. But if I see a child presenting at the age of 8 to 10 days with serum bilirubin of less than 12 milligram per GL, I may examine, take proper history, and not necessarily admit. So the age of presentation matters. The level of bilirubin matters, as we will soon see, and then the rate of rise of bilirubin is very important. So the key points in management, the ultimate aim is to prevent bilirubin from getting to neurotoxic level. We don't want it to cause damage to that immature brain. And then babies that are discharged before 24 hours must be assessed for jaundice every 2 days. Early initiation of breastfeeding should be encouraged, and the baby should feed at least 8 times. I expect it to be much more than 8 times, but at least 8 times per day. Continue breastfeeding, even if there are feeding difficulties. You can use express breast milk or formula supplementation as necessary. Now, discourage discontinuation of breastfeeding except in suspected case of breast milk jaundice. Well, some studies, most studies say that all you need to do is to stop feeding, for about 24 hours, and then take your serum bilirubin, which would have dropped. You can recommence breastfeeding afterwards because the serum bilirubin is not likely to rise again. Also, there has been no reported case of a child having kernicterus from breast milk jaundice. So, prolonged jaundice greater than 14 days for term, greater than 21 days for preterms. Then you begin to investigate this child and see would it be conjugated hyperbilirubinemia. So, history taking, we say, is very important. So, family history of jaundice, of anemia, of hemolytic disease, or G6PD deficiency. A family history of liver disease, galactosemia, and so especially for those with conjugated hyperbilirubinemia. We've talked about ethnicity, and then sibling with jaundice, maternal diseases like diabetes mellitus or intrauterine infection, maternal drugs intake, sulfonamides or oxidants, in G6PD deficiency. Birth trauma, we've talked about cephalohematoma and bruising, and then you take a feeding history. Physical examination, you want to check the scalp, is it increasing, and then is it limited to sutural lines, it's not crossing the midline. And then the size of the baby, prematurity, then the small for gestational age babies are usually plethoric. And then breathing, you want to check for pallor, microcephaly or choriorrhea. These are pointers to, could this child suffered intrauterine infection. Omphalitis, is a pointer to infection, and then hepatomegaly. So in investigating, what exactly do we do? Initial evaluation, we want to take blood for total and direct bilirubin. And then you want to know the blood type of the infant and the blood type of the mother. And you want to check your PCV and do a direct Coombs test on the infant, especially if it is not the first child in a rhesus negative or ABO and a rhesus negative mother. So you want to do a Coombs test to know if the child is sensitized in utero. So later evaluation, as you continue your management, of course, you want to do your red blood cell smear, looking for reticulocyte count or evidence to support hemolytic disease. You want to do a blood culture, urinalysis to rule out infection. You want to do a thyroid function test, especially in babies with hypothyroidism. It's sad that we don't even screen them. We don't do newborn screening for hypothyroidism, but babies, especially those with prolonged jaundice, think hypothyroidism. And then, this I put here, end-tidal carbon monoxide is not, what it is used to just know, as the rate of rise of bilirubin, so it's not like an investigative thing per se, but it helps, in managing, in knowing, how bilirubin rises. Then the treatment, basically, it's phototherapy or exchange blood transfusion. I have limited it to what we do in our environment. But suffice to say that there are some other things once upon a time, phenobarbital is now obsolete. It's not one of the first things you think about in management, but just so that we know, phenobarbital increases, helps the expression of the bilirubin. Then the phenethyloprophorins too, but let's limit it to what we do in our environment. So phototherapy, exchange blood transfusion, and then we give supportive treatment like hydrate the child and give antibiotics where needed. What are the risk factors for neurotoxicity? You have isoimmune hemolytic disease, we've been talking about it, G6PD deficiency. If the child is associated, so the blood-brain barrier is already compromised, and so, the threshold for developing neurotoxicity is lowered in babies with birth asphyxia. Significant lethargy is a risk factor for neurotoxicity. It's a red flag that something is happening. Temperature instability, sepsis, acidosis, and hypoalbuminemia. Don't forget, we said, it is albumin that binds to bilirubin and keeps it in the conjugated form. So, now, risk factors for neurotoxicity, that's the epidemiologic risk factors. Total serum bilirubin, less than 20 milligram per DL. It is rare onset of bilirubin toxicity unless the baby is vulnerable. For instance, baby has birth asphyxia, so less than 20 milligram per DL, the risk for neurotoxicity is not so high, except, again, like I said, the child is vulnerable. Greater than 25 milligram per DL and compounded by sepsis, the risk for neurotoxicity is high. 25 to 30 milligram per DL, 1 in 6 will sustain kernicterus. 35 to 35 milligram per DL, 1 in 7 will sustain kernicterus. Greater than 35 DL, almost all of them are at risk of kernicterus. So treatment modalities, phototherapy. Phototherapy, it can be overhead or it can be the newer LED lights. Right now, we're talking about Billy blankets and, a lot of innovation. So intensive phototherapy is recommended. Distance between the child and the phototherapy units, 10 to 40 cm, and then ensure adequate fluids and shield the eyes. The light range for is usually between 420 to 450 nanometers, and 2 lights have been found, in this range, and they are the blue light and the green light. So those are the lights that can be used as phototherapy. For extended blood transfusion.
Sorry, Dr. Olutekunbi, we lost you for some seconds. So if you can just repeat what you said last.
Okay, so I talked about the range, for the light, that the light, the spectrum, the range for phototherapy is usually between 420 nanometers to 450 nanometers. And I talked about the colors of light that fall within the spectrum. I said the blue light and the green light. Those are the colors of light, that fall within that spectrum. But that is not to say, because most times it's people would argue, what about sunlight? Does sunlight not have a role to play? The answer is quite controversial. Some people believe that there are harmful ultraviolet rays in sunlight that can harm the baby. So usually the mothers are encouraged, if you're going to use sunlight, to put the baby out in the early morning sun, and take the baby back into the house when the sun is becoming hot. Some centers actually have some houses, that they built, with transparent materials that actually is able to filter off these dangerous ultraviolet rays. I was going to bring up a picture, but I couldn't do it because of the home pass. In the past few days. But suffice to say that if you're going to advise any mother to do that, to put the child in sunlight, then it should be the early morning sun. So extend blood transfusion. If phototherapy fails to keep the serum bilirubin from rising from dangerous to dangerous level, you're doing your serum bilirubin and you are getting a rate of greater than 5 milligram per DL per day, please exchange the blood of the child. So the rule of thumb, since because of all our limitations, so there's anything above 20 milligram per DL, we'll begin to prepare for extended blood transfusion, especially if the child is within the first, is within 0 to 5 days of age. Again, is a rule of thumb. Then the rule of 10 for the preterm babies. So here what we do is multiply the weight of the child by 10. If the serum bilirubin is greater than that, then you begin to prepare for exchange blood transfusion. And also you use the rate of rise of bilirubin. Please, can you still hear me?
Yes, we can. We can hear you.
Okay.
Go ahead, Doctor. Yeah.
Yeah, I'm having problems with moving my slide. Just a minute, I'm having some technical problems here.
Okay, if it persists, we can you can stop sharing and then we'll pull up to this slide if it continues.
Okay, I don't mind. I think it's persisting.
Okay. If you could stop sharing, could you move over to this exchange blood transfusion slide? Just give us a second, everyone, to pull up the slide. Thank you so much, Annie.
Okay, thank you. Okay, so good. So can the next slide, please? The next slide. The next slide, thank you. Okay, so well, this is a picture, of this is the overhead phototherapy unit with a child. Next slide, please. Next slide. And then this is the picture of a child, undergoing exchange blood transfusion. So in exchange blood transfusion, basically what you do is to exchange twice the blood volume of the child. And then the procedure is a very aseptic procedure. And you should not exchange the blood so fast. At least exchange blood transfusion should take over an hour, and you stop intermittently to examine the child, especially the heart rate, the activity of the child. Next slide, please. Now, the bind score. I would even advise that we all have this pasted up on our wards. I mean, especially the emergency room and the neonatal unit. This is used in babies with severe neonatal jaundice to assess the severity and progression of acute bilirubin encephalopathy so that you can intervene in time. So it is a predictor of bilirubin encephalopathy, but it is limited in the fact that you can only use it for near-term and term infants and not for preterm infants. Next slide. Okay. This is what the bind score looks like. So there are three parameters that you measure: the mental state of the child, the muscle tone of the child, and then the cry pattern. So, and these are the clinical symptoms that you look out for. So, mental status: if the child is normal, you score sleepy but arousable, lethargic, having apnea, semi-coma, you score the child 0 to 3. For muscle tone, you do the same thing. Is the muscle tone normal? Is it having persistent or mild hypotonia? Is the baby twitching? You score. And then the cry pattern of the child. Is it normal? Does the child have high-pitched cry when aroused? Or is it crying is so inconsolable? You score the child. When you have scored for each of these parameters, mental status, muscle tone, and cry pattern, you now had the bind score. So this tells you, the score. If it is mild ABA, then the score is between 1 to 3. The child has subtle signs of bilirubin encephalopathy. For moderate, it is between 4 to 6. Urgent bilirubin reduction intervention will likely reverse the acute damage. So it helps you to rise up and intervene on time. A score between 7 to 9 is advanced encephalopathy. So urgent bilirubin reduction intervention is needed to prevent further brain damage. So you want to prevent further brain damage for 7 to 9. For 4 to 6, there's a likelihood that if you intervene on time, you can actually reverse the acute damage. So I encourage every one of us to get one of these and put it up in our workstation. It will help us to help these babies. Next slide, please.
Okay, so thank you very much, Dr. Olutekunbi. We're going to move to the next part of this, which is the case presentation. And this will be taken by Dr. Abimbola Aboderi, who is a senior registrar at Massey Children's Hospital. Immediately after this case presentation, then we'll go into discussing both the didactic session by Dr. Olutekunbi and this case presentation by Dr. Aboderi. So please keep your questions coming. We already have one clarification to be made that Dr. Waje, Medical Director of Pediatric Partners, has put in the chat. I would be asking this after the case presentation. So over to you, Dr. Aboderi. If we could make sure that Dr. Aboderi is unmuted. Dr. Bimbola
Thank you.
Aboderi. Okay, thank you. So
thank
over
you,
to you.
Good afternoon once
wonderful.
again. And I want to thank Dr. Olutekunbi for this opportunity to be part of this presentation. And I'd like to stand on the existing protocol. Okay, I'm taking the case presentation. It's a 3-day-old 10-male newborn brought into the emergency room on account of yellowness of the eyes and the body of a day duration and refusal to suck of 6 hours prior to presentation. It was delivered at home to a 29-year-old now primipara who had pregnancy supervised by a nurse in the neighborhood. Pregnancy was uneventful at about 48 hours prior to delivery. She had spontaneous membrane rupture, but labor was not prolonged. There was no peripartal fever, likewise was not foul smelling, no vaginal discharge. Baby was said to have cried at birth. Birth weight was unknown. It was given glucose water because lactation wasn't established, though it suckled on breast shortly after birth. It was noticed to have yellowness of the eyes after 24 hours of life, which progressed to involve the whole body. There was history of poor suck 6 hours prior to presentation with associated lethargy. There was no seizure and no loss of consciousness. Mother's blood group was unknown. No history of exposure to heterogenic agents such as mentholatum, silverbird, etc. He was given Ampiclox, paracetamol, and Abidec. And due to onset of poor suck, he was brought to the hospital. The baby was there to be immunized as at the time of presentation. He was the first child of both parents in a monogamous setting. At presentation, he was found to be conscious but lethargic, icteric up to the thigh, and was febrile with temperature of 38.3 degrees centigrade. It was acyanosed, no pedal edema, it was not dehydrated. Weight at admission was 2.9 kg. The length was 48 centimeter. OFC, that's occipitofrontal circumference, was 34 centimeter. Excuse me.
Go ahead, Dr. Aboderi.
Thank you. Central nervous system examination revealed a conscious but lethargic neonate, was hypotonic, with a bind score of 3/9. The cardiovascular system revealed heart rate of 164 beats per minute, which was tachycardic for the baby. With first and second heart sound here, there was no murmur. The respiratory rate was 68 cycles per minute, which was tachypneic, with a bronchospular breath sound. The abdomen was full, was soft, smooth respiration. There were no organomegaly. And a diagnosis of mild acute bilirubin encephalopathy and severe anemia secondary to sepsis to rule out ABO incompatibility was made. Next slide. The baby was planned to be worked up for exchange blood transfusion. Parents were counseled, but declined the procedure because they needed to consult the family and spiritual leaders. And these are part of the problems we face in the hospital. They came back after 24 hours at exactly 10:20 p.m. the following day and finally consented to the procedure. At this time, compatible blood was not available in the hospital, and other laboratory investigations were not available. However, the baby was commenced on intensive phototherapy, and EBT was delayed to the following morning when blood was available. Examination at the time of readmission showed a deeply icteric baby with hypertonia, depressed primitive reflexes. He was already having retrocolis and subtle seizure, with a bind score now of 7/9, just within 24 hours of presentation. And the diagnosis was reviewed and now have an advanced acute bilirubin encephalopathy with severe anemia, secondary to sepsis to rule out ABO incompatibility. The mother's blood group was O positive. Baby's blood group was B positive, which shows the incompatibility that was initially suspected. The total serum bilirubin was 34 milligrams per DL with a direct, that's the conjugated fraction of 2.1 milligram per DL, which is less than 15% of the total serum bilirubin, so more of unconjugated hyperbilirubinemia. The full blood count result showed a packed cell volume of 23%, which showed anemia in the baby, severe form of anemia in the baby, a leukocytosis with neutrophilia. Direct Coombs test was positive, and the blood culture was negative. The child continued on phototherapy after the exchange blood transfusion. Intravenous antibiotics was commenced and intravenous fluid was given. Feeding was via NG tube after 24 hours, that's post-EBT. Then it graduated to cup feeding and finally to direct breastfeeding. Total serum bilirubin level gradually dropped until the 6th day on admission when phototherapy was discontinued at total serum bilirubin of 9.7 milligrams per DL. And with a post-EBT, that's post-exchange blood transfusion packed cell volume of 38%. He was discharged to follow-up clinic after 8 days on admission. Initially, the parent defaulted from follow-up, but presented at 6 months with inability to achieve net control and global hypertonia. Thank you.